In this video, we are going to explore how to think in OET listening part C. Before we even start the video, I want you to understand how OET expects you to think in part C. So this is not about catching keywords. This is about understanding why the speaker is talking and what they really mean. So in part C, the speaker will give facts, but facts are not the answers, right? OET wants to know, what does the speaker believe? What are they criticizing? What are they supporting or questioning? So instead of asking, what did they say? You have to ask, what is their attitude towards this? Got it? And the next one is identifying the main concern. Almost every Part C extract has one main concern, one main problem, one main message. Very often, the correct answer will reflect something the speaker is unhappy about, something they think is being done in a wrong way, something that needs to change. If an option sounds neutral or positive when the speaker sounds critical, then it's probably wrong. Got it? Then the next strategy is watch out for cause versus consequence traps. This is a classic OET trick. The speaker may say, this causes that, but OET will give you option like the cause, the result, something related but not central. Only one option matches the speaker's main focus. You have to identify that. So always you have to ask yourself, is this the reason they are complaining about, or they are just talking about the outcome? Got it? And the next strategy is don't choose extreme answers, because in real OET exam, speakers are usually balanced professionals, right? You have to be very careful with words like never, always, completely, banned, no benefit. If the speaker says, I'm not saying this should never be used, then any option suggesting total rejection will be automatically wrong. Got it? And reframe behavior and language. Part C often tests whether you can reframe what the speaker says. For example, challenging behavior might actually mean unmet needs. Practical solution might actually mean convenient but flawed. Effective in the short term might hide long term risk. So, OET loves testing whether you understand what's underneath the words. Okay, you always need to dig in the words in order to understand its tone and the context and its meaning. And final question is usually big picture. The last question in each extract is often reflective, philosophical, broader than the rest. So it's not about a detail, it's about values, priorities, mindset, overall approach. So zoom out and you have to ask yourself, what does the speaker ultimately want us to rethink? Got it? And one golden rule, very important. If an option is technically true but not the speaker's focus, it is still wrong. Correct answers are not just true, they are the speaker's main intention. We are going to hear a geriatric psychiatrist speaking during a professional webinar for healthcare workers about the use of antipsychotic medicine in elderly patients with dementia. So let me say this for you. When we talk about managing behavioral symptoms in dementia, the conversation often turns very quickly to medication, particularly antipsychotics. And I understand why. These drugs can appear to offer fast, visible relief, especially when a patient is distressed, agitated, or even aggressive. However, what concerns me is not the existence of these medications, but how routinely they are used as a first response rather than a last resort. In many care settings, staff are under enormous pressure. Limited time, limited resources, high patient to staff ratios. In that environment, medication can feel like the most practical solution. But we have to pause and ask ourselves, practical for whom? The evidence consistently shows that while antipsychotics may reduce certain behaviors in the short term, they also increase the risk of serious side effects. falls, cardiovascular events, and even increased mortality. These are not abstract risks, they are outcomes we see far too often. What's particularly troubling is that many behaviors we label as challenging are actually expressions of unmet needs. Pain, discomfort, confusion, fear, loneliness. These are not symptoms that can be medicated away without consequence. When a patient is pacing or calling out repeatedly, they are communicating something, even if they can no longer do so in words. Non-pharmacological approaches, environmental adjustment, consistent routines, meaningful social interaction require more effort, more training, and more patience. They don't offer instant results, but when implemented properly, they not only reduce distress, they preserve dignity. Now, I'm not suggesting that antipsychotics should never be used. There are situations where the risk of not intervening outweigh the risk of medication, particularly when there is immediate danger. But those decisions must be individualized, regularly reviewed, and made with full awareness of the trade offs involved. Ultimately, the question is not whether antipsychotics work, the question is whether we have become too comfortable relying on them at the expense of truly understanding the people in our care. Interesting, isn't it? Now, let's move on to the question here. The first question is, what is the speaker's main concern about the use of antipsychotics in dementia care? So we can just go through the options. And the right option here is option B. They are used too readily instead of other approaches. Got it? And for the second question, what does the speaker suggest about care staffing working conditions? They discourage staff from following best clinical practice. They contribute to a reliance on medication. They prevent non-pharmacological care entirely. And you know the correct option, right? Option B. Yes, they contribute to a reliance on medications. And for the third one, what point is the speaker making about challenging behaviors? They are often exaggerated by caregivers. They usually indicate disease progression. They can represent unmet patient needs. Yes, the doctor clearly addressed they can represent unmet patient needs, right? So option C is the correct option. And for the fourth question, why does the speaker describe non-pharmacological approaches as difficult to implement? The options are they require more resources and patience, they lack strong scientific evidence, they are resisted by families, and the correct option is option A. They require more resources and patience, right? And question 5, what is the speaker's position on the complete avoidance of antipsychotics? He believes they should be banned in elderly care. He accepts their use in carefully justified cases. He feels their benefits outweigh the risk. Yes, the correct option is option B. He accepts their use in carefully justified cases. That is the speaker's position, right? And for the question 6, what broader issues the speaker encouraging listeners to reflect on? Whether current guidelines are outdated, whether medications are being prescribed legally, whether patient centered understanding is being overlooked. Of course, the right option is option C. Got it? Because option C, if you see here, this is a big picture entrance question. The final line shift from medication to mindset at the expense of truly understanding the people in our care, right? So he is questioning whether human understanding has been replaced by convenience. So option C is the correct option. So that's all for today's video. Kindly like, share, and subscribe for more OET tips. See you in the next video. Bye bye.